All right. So, okay, the first thing we're going to do is go through Unit 6, the muscle portfolio. I don't know where you guys are on that, but I do want to go through. Uh, oh, there you go, 18. So, yeah, yours is right down the middle, right? Mine's a oh 05 or oh 04. Yours is 10. So, yeah, we'll go with oh 08. I think that's what my stove digital says up there. Uh, I think it's about 2 minutes behind my cell phone. So that's probably the real time. So anyway, that's the best time, right? Stove time, oven time. So anyway, Unit 6. I know several of you have already put your Unit 5 skeletal system in the Dropbox. I'm in the process of grading those. I should have those grades done by the time I go to bed tomorrow night is my goal. Plus, that gives other students a little more time to get them turned in. But those grades should be updated. And in the Padlet grades as of last night should be updated again. There are still some anonymous postings. So if you go and look at your grade book and you know that you did a Padlet and there's no grade, please let me know so I can get that fixed. Let's see what else is going on. Anyway, so Unit 6 hi Brittany, Unit 6 muscle portfolio. We just started, so perfect timing. We're going to go through the muscle portfolio. So I'm going to do that now. I have to change my share screen. Let's see, new share, and then we're going to click that. We're going to go there. Okay, good. So here we go. Again, most of you have turned in your Unit 5, so I hope at this point you've at least started on the muscle system one. So I trimmed out some of the definitions. So on my key, you're going to see more definitions than you had. So don't be freaked out by any of that. All right, so here's where we are. What I wanted to go through tonight is look and see, again, provide you with a little bit of heads up on what I'm looking for some of these identifications. Again, if I'm going too fast, this is recorded. I recorded the daytime session as well, so you can always view them there in YouTube. So anyway, I'm mainly focused on muscle name. When it comes to the function of the muscle, I'm mainly looking at what the action of the muscle is. So you can be fairly broad with that. Again, I think more importantly for me is that you know, and for you right now, is that you know the name of the muscle and approximately where it's located. All right. So occipital front. So letter A is pointing to the occipital frontalis. Specifically, it's pointing to the frontalis muscle. So you could have either one of those for that. You could even have epicranius potentially, and that one wrinkles the forehead or raises the eyebrows. And then we look at the temporalis muscle for letter B, which again elevates the mandible or closes the jaw. And then we see the two orbicularis muscles, letter C and letter E. One is the oculi, one is the oris. And then letter D, going for the zygomatic muscle. Again, you could put zygomaticus major. If you just have zygomaticus, that's fine too. Again, it's an exercise in again knowing your anatomy. So if you see a muscle, if you know this is the zygomatic and a muscle's coming off of it, it's probably the zygomatic muscle. So anyway, that's what that is. Masseter, the chewing muscle, kind of in the cheek area there, that helps with the temporalis for closing the jaw. And then we had the SCM, or the sternocleidomastoid, coming off of the mastoid and going down to the sternum and the clavicle. And then letter H is the plate muscle, the flat muscle called the platysma. And that one kind of juts out, kind of pulls down the mandible a little bit. So anyway, let's see. Trapezius is next, the big kind of kite shaped or diamond shaped muscle of the shoulders and kind of the middle back. And then letter B is pointing to the infraspinatus. Letter C is the teres major. And then D is the big kind of middle lower back cape muscle. We call it the latissimus dorsi. And then letter E and letter F are pointing to the gluteal, two of the three gluteal muscles we see, medius, kind of off toward the hip side or the lateral aspect, and then the more posterior aspect being the gluteus maximus. Okay, so then we come down. We have an anterior view of the chest, thorax, and trunk area. We see letter A pointing to the deltoid, again, a site of a lot of your intramuscular shots. And then we have the pectoralis major for letter B. And the letter C, you could have a couple of items. If you just put intercostal muscles for letter C, that's fine. It almost looks like it's pointing to a rib, but that's kind of your clue there too. So just intercostals would be fine. If you have external or internal, that's fine too. There's a serratus group, what we call the serrated, kind of the, like a serrated edge is kind of a bumpy edge. Those are also kind of located under that area as well. So anyway, intercostal is what I'm going for. And then D is the biceps brachii. And then we come over and we look at some of the oblique muscles. We see the external oblique and then the rectus abdominis and then the internal oblique coming across the way. And then letter H, we're looking for, you could just put, in fact, I'll even change it, flexor group would be fine for that one. Again, I don't need you to know necessarily the specifics of these individual muscles of the anterior and posterior forearm. But again, if you know that the anterior group is the flexor group and the posterior group is the extensor group, then you're doing pretty well. All right, so you don't need the specifics for that. There is one though on the kind of the lateral edge of the forearm, the brachioradialis, that I think is probably a good one to know. Letter I there. All right, and then that takes us over to the little more of the arm, more zoomed in. We've got the posterior and anterior views. We've got the triceps muscle and then the biceps muscle, and then both brachii. And then, of course, letter C is sandwiched in between. That's the brachialis muscle. And then again, here's B, the biceps. And then letter D is again pointing to that brachioradialis. It's on the lateral aspect of the forearm. And then letter E is the extensor group. Again, we're looking at the posterior aspect. And then letter F is going to be those flexor groups again. So again, flexion always means we're decreasing the angle of a joint. So if we're at 180 degrees and we go to 90 degrees, there we go, that decrease the angle. Okay, so that's flexion. Extension is just going back, is increasing the angle. So if you're at 90 degrees, you go back to 180, that's extension. If you go past the 180 mark, that's called hyper extension. And some of our muscle, some of our joints, it's okay to do hyper extension. Whereas other like hinge joints, you don't want to have hyper extension like the elbow or the knee. All right, so we go down to the lower leg or the lower body, the lower extremities. We've got that TFL or that tensor fascia lata muscle. And again, it plugs into that IT band, which I don't, you can see it over here as well, the IT band. That's not one that you necessarily needed to identify, but I know we did talk about it a little bit. And then we get into the quadriceps group. We can see the primary quad muscle, the rectus femoris, and then the two vastus muscles that are superficial. One is more medial, so that's the medialis, and then the other one, and it's a little meatier too, toward the medial side. And then letter D is going to be the vastus lateralis. And then over here, when we look at I, we've kind of peeled away some of this musculature so you can see down deep to that area, and that's where you find the vastus intermedius. So that's what letter I is trying to get at. Is inter means between, of course. So we're in between the other two vastus muscles. Then we come up here, and F and G, I'm okay if you just call the, adductor group, an adductor group. You don't necessarily need to know. Again, if you're going to work in orthopedics or PTA, whoops, double U, double D. There we go. If Anyway, unless you're going to work in orthopedics or PTA, you probably aren't going to necessarily need to know the specific names of the adductor group, but so if you put them in, that's fine. Okay, and then H is the sartorius. That's that talar muscle, the longest muscle of the body. All right, that moves us into the posterior, or the posterior aspect of the lower extremity. We see the gluteus maximus once again. And then we also have the three hamstring muscles. We look at letter B. That's the biceps of the lower body, the biceps of the leg. We call it the biceps femoris. And then letter C and letter D. Those are the two semi muscles, and the tendinosus. That's the one that forms that really large tendon that's right on the back of the leg or right behind the knee, kind of on the medial side. There's a big tendon back there. If you follow, it's kind of sensitive too. Uh, we call that the popliteal region or the popliteal region. But anyway, that big tendon on the back behind the knee on the medial side, that's going to be part of the semitendinosus muscle. And then kind of nestled more medially than the other three, but it's a little bit more hidden, is the membranosus. There's a lot of M's. Semimembranosus is most medial, okay, on the back there. And then soleus gastrocnemius, of course, are your lower leg muscles. We see the more superficial being the gastrocnemius. And then this side, the left side, we remove the gastrocnemius to expose the soleus. Okay. And then these, I left this one off. This is cellular aspects. This one, I believe you guys do have. I left it in there. WIDS only has us going to this kind of stopping at the muscle fiber. But I put these in to go a little further because we spend a lot of time here next semester, at least a week, maybe even 2 weeks. And if you already know a little bit about the naming, then it'll make things a little bit smoother next semester. But we do have, so I'm going to start at the macro scale. We've got the belly of the muscle letter. So if you put belly of the muscle for E, that's fine. I am going after maybe like the epimysium, or you could put fascia even for that one, maybe even tendon. Okay. But yeah, letter E, probably epimysium. That's that sheath or surrounding of the muscle belly. And then we look at the muscle belly, and you can see it's got a bunch of chunks. Those are letter F. We pulled one out. Those are the fascicles of the muscle. And then we kind of pull one of those out and isolate one of those. And that's when we finally get to a muscle fiber, which we also know is being called a muscle cell. And then we pull another one out. There's even more to go. We see there's bundles, even smaller bundles within those fibers. Those are myofibrils. And then finally, we get to the smallest level of muscle filaments. Okay, we have the thick filaments and the thin filaments. So filament, fibril, fiber, fascicle. Yeah, anyway, a lot of alliteration in A&P. All right, so these we'll just keep cruising. Paul, he's still lingering a little bit. We're probably going to move on to figure out what the space bar allows you to move the. Well, okay. Well, good. At least you figured it out. Better late than never, right, Stephanie? All right, good. So let's see. Um, I'm going to try. I don't know if it's going to work out. Next week on Thursday, I have an iPad, and supposedly, when I go to share for Zoom, I can share from my iPad. But IT, of course, I have a college computer, and so I have to. Something has to be downloaded to allow it to happen. So trying to circumnavigate that a little bit. Maybe use my home PC, but. We know that when we're going through visible body, part of the reason I don't do it a heck of a lot with you guys is because it's so sketchy and doesn't really, it's glitchy. It's not really sketchy, maybe glitchy. But if I could beam it, mirror it, my iPad into Zoom, which that capability does exist, that's my goal. So then I can share the screen, and then we'll be able to blow these things up so you can see them a lot better. So anyway, let's see, Paul. We've got again, the nurse is she's something else. So I don't know. We're done with these two though. After this is it. This is it. No more Paul. No more nurse. So Paul is getting hormone therapy. Um, the hormone therapy is decreasing his testosterone, and we know that testosterone generally is going to cause muscle mass increase. So that kind of takes you down to the second question. First, testosterone builds muscle. Paul's on a hormone replacement that's going to decrease testosterone, so we would probably see lower muscle mass or a decrease in muscle mass, but we would also see usually the specific hormone an increase in muscle in fat. So that is more likely what's causing Paul's soreness. He's maybe beyond sore. He's in pain, but he's got a lot going on. We can all agree on that. But I don't think the radiation could certainly be causing some of his muscle pain. Right, everybody's different. That is a side effect potentially, but more than likely, the hormone therapy that's causing his testosterone levels to go down. We're seeing some cellular changes going on that are decreasing his muscle mass, and that's going to be sore. It's going to even be painful. So the nurse says, "Oh, just if you're in pain, just rest, take it easy, don't do anything about it." In essence, I don't know if that's necessarily the best advice. I think Paul does need to monitor his resting, of course, but I think light exercise, even just walking, getting some movement, maybe even some therabands, something to kind of help with the muscle tone, and stretching certainly is going to, you know, certainly if the doctor approves, we do want Paul to be at least stretching a little bit, doing maybe just some light walking, or but other than that, I mean, uh yeah, he's got a lot going on, for sure. So anyway, hopefully that answers some of your questions with this. Denise, yeah, she right. All right, so let's go. We're gonna stop this particular share, and I don't know if that's going to take us back to our original. There we go. Okay. Now I want to go over to Blackboard real quickly and show you a couple things. Um, Nothing real majorly different than last time, but there are a couple of minor differences. Again, you do see 1 through 9 are available. This is the rest of the semester. I haven't really started beefing up unit 8 or 9 that much yet. Unit 7 is getting, I kind of gave it the treatment last night a little bit, added things in like that you're used to seeing, without bombarding you with too much. Now, here's where kind of a minor change comes in. I'll talk about in just a second. So this is familiar, of course. Padlet, again, like every unit, you're going to have these last three. You have 3 units to go, but we've condensed a couple of units into each. So you do still have 6 total Padlets to do. One of them, 2 of them in unit 7, 2 of them in unit 8, 2 of them in unit 9. So the unit 7, one of the Padlets is up and running. So if I click that'll take you to the endocrine system and central nervous system Padlet. I may put another column over here I found something today. I'm going to add something over there. But anyway, that's the beauty of Padlet. Things can keep getting added. And sometimes there we go. So anyway, uh, there'll be another Padlet for this unit that's going to have peripheral nervous system and a couple of other items as well. So, and then I'll put the link in there when that one opens up. It'll have autonomic nervous system, senses, and peripheral nervous system. So it'll be about 5 or 6 videos for that as well. And that one again, I'll put the link in here once I upload it. Hey, and then the rest of this you're used to. Now, you may notice though that the comprehend and practice, where I was putting links that would take you to reviews, they would take you to other items within OpenStax. I've eliminated those, but they're not necessarily eliminated. I discovered something with OpenStax that I was able to upload it into our course shell yesterday, which is very helpful for all of us. But each of the chapters that we do in this unit, and notice chapter 16 is missing. We don't really do much with 16. Chapter 12 does have a few things we don't go through. We don't get into action potentials. We don't get into some of the physiology that you're going to find in 12. But anyhow, if you click on these folders, basically they just open up the hyperlinks that I had before. So I was putting in hyperlinks to the review, to the in OpenStax, to the key terms, to the questions and that. So they already do that for you, I discovered yesterday. So that's nice. See, we all figure stuff out, and it helps for the future. So anyway, I don't know if any of you, I don't know how much you guys use OpenStax. I hope you use it. I don't know beyond just looking at the verbiage in the chapters, but again, there are the key terms, there are review questions, there's all kinds of good stuff in here. So the chapter review, remember, gives a really good breakdown of what's going on. But anyway, each of these folders goes with each of the chapters, and then they're going to just be hyperlinks that'll take. So if I click key terms, it's going to take me right to the key terms section. So I don't have to dig around in OpenStax trying to find it. So there it is, key terms, for instance. I'll go back there, kind of zipped away from it fast, but there's that. Basically, each of these, see, introduction and so on down the line, chapter review. Basically, what they did is created hyperlinks for all of those. So anyway, if you click chapter review, it'll take you right out to the chapter review. So anyway, that may be of some help. Again, I hope you are using OpenStax anyway, but there you go. So those will be in there like that, and then Quizlets. I didn't put Quizlets in this one. I think at this, I can if you want, but I think at this point, students who are using Quizlet, who are acclimated to Quizlet, you know how to get to Quizlet. You just type in nervous system, type in endocrine system, whatever you want, and Quizlet will help you. If you want me to keep putting the links in, I can. That's no problem. But anyway, that's a couple of things to kind of tidy things up a little bit. And then again, I wanted to reiterate, I did put exam 8 in. So both, let me go back to that one real quick. Both exam 7 and exam 8 are available now in Blackboard. So you do have 2 exams in this unit, 2 exams in the next, and 2 exams in the last unit. All right, so that's that. Let's get to the new business so we can get on with life. Again, the review questions. I can't emphasize enough. I would highly recommend printing these off when you start the unit. So we're getting into unit 7. I would print these off, and as I'm doing my I would print off my portfolios. If you're doing writing stuff, I would print off my portfolio assignment. I would print off the review questions, and and then I would have my visible body, OpenStax, my PowerPoint slides. And I would just be going through and kind of answering all these review questions as you're filling out your portfolio. Because once you go to take your questions, or once you go to take your exam, your question, these are from the pool I mentioned last time. So you're golden at that point. I mean, so get these. You know what I should do in future semesters? I should call these preview questions. Review, it implies that you're going to do it at the end, right before you take the test. But you've heard it before. I'm not going to keep harping on it. So anyway, I'm going to trim that up. You guys look like you're ready to rumble. So let's get going. And again, I'm not going to go through a heck of a lot tonight. I do want to allow you guys time to take care of yourselves and start the weekend. Boy, they really screwed the weather prediction for today. It was all for a week now. They've been saying 70s and sunny on Thursday, and I don't know if it got above 60 today. And it certainly, I don't know if the sun ever came out. So anyway, yeah. Well, the weather folks, we guess we know what we get. So anyway, nervous system cells. The chapter 12 does go through some items that we really are not interested in quite yet. We're very interested in some of this stuff next semester. But right now, again, our focus is really on the anatomical aspects. So as we look, and some of these we've heard before, but as we kind of introduce you to the nervous system or reintroduce you to it, we know that along with the endocrine system, we're communicating with all of the systems, all of the organs, and hopefully all of the tissues and cells of the body. So the nervous system exists as a communication pathway. Remember, we're going to see sensory coming into the center and motor going away from the center, out from the center. We do see three things, that's it, make up the nervous system: brain, spinal cord, and nerves. So that's it. Three things: brain, spinal cord, and nerves. Seems pretty straightforward. Have a good night. See you next week. I'm just kidding. It's not. Yeah, anyway. All right. So brain. So here's a nice illustration of that. Brain and spinal cord. We know that's the central nervous system. And so we're going to focus a little bit on that tonight with some specifics. We're at least going to get through my goal is to get through the spinal cord. Now, next Tuesday, then we'll pick up on the central nervous system, talking about the brain, and then we'll get in on the peripheral nervous system next week as well. But anyway, it's all interconnected. It's just a bunch of wires, basically. And again, we see that these nerves are organized in a way that the sensory can detect changes going on in the external environment, as well as certainly changes going on in the internal environment. So that's really the goal, is to detect changes, or just kind of monitor homeostasis too. It's not just about detecting changes, I suppose, is I guess it's part and parcel. We're monitoring homeostasis and then detecting changes when we get too far out of the homeostatic norms, and then those signals get sent to the brain. Brain then evaluates that information and then initiates some sort of a response, which is going to be a slightly different pathway, more of what we would call a motor pathway or an effector pathway. So we'll be seeing a little bit more of the specifics as we go over the next couple weeks. We will see some subdivisions even beyond just the central nervous system of the brain and spinal cord, and then the peripheral nervous system or the nerves. We will see some other subdivisions, especially with the peripheral nervous system. So keep that in mind as we go. Our focus, again, is just kind of tonight to introduce you to, our focus tonight is just to kind of introduce you to the very basics of the nervous system as a whole, and then dig a little deeper with the central nervous system parts, the brain and spinal cord. And again, the peripheral, so that's what the last little section was, brain and spinal cord. Peripheral nervous system, again, is just going to be in the periphery of the center. These are going to be the nerves. So we're going to see primarily two different types of nerves. We're going to see either cranial nerves or spinal nerves. Now, cranial nerves are going to originate from the brain, hence the term cranial. Spinal nerves are going to be nerves that originate from the spinal cord. Okay, so we can assume for the most part that if it's a nerve from the cranium that's plugged in directly to the brain, that most of these signals and detections of change that are going on, most of the responses to those changes that are going on are going to really be focused on then things that go on in the cranium or around the cranium. Spinal nerves, then those are going to be primarily then nerves that detect change and ultimately then deliver some sort of response to items below the cranium or that come off of the spinal cord. So we'll see that as we go as well, primarily next week and a little bit the week after that. uh, the divisions of this peripheral nervous system. We can divide the peripheral nervous system, these cranial and spinal nerves. They also have what are called afferent and efferent pathways, or afferent and efferent divisions. Afferent pathways are going to be the incoming sensory pathways. So whenever we're talking about afferent, we're talking about sensory. Whenever we're talking about efferent with an E, think of like an effect. So the effect or the efferent pathway is going to involve some sort of response pathway. So afferent is the stimulus, efferent is the response. Afferent is the sensory, efferent is the motor. Okay. So, um, furthermore, we can divide that peripheral nervous system a little bit, or we could divide it even further into what we call the somatic nervous system versus the autonomic nervous system. So, even within all of these different sensory nerves and motor nerves, we're going to have kind of even a separate set of pathways and divisions that involve more or less kind of an awareness or of body movement, more or less like voluntary activity. So, somatic, remember, soma means body. So, whenever we see soma or somatic, we're usually thinking of the body of something. And in this case, it's your body. And in this case, specifically, it's your skeletal muscles. So when we're talking about the somatic nervous system, this is going to be a motor pathway involving skeletal muscles typically. So oftentimes we would think of the somatic pathway being a little bit more maybe voluntarily controlled. Okay. So the autonomic nervous system is just like it sounds, is automatic. So remember, if we have, remember that we have three types of muscles. We have skeletal muscle, which we just saw last chapter, but we also just saw it on the last slide. When we're dealing with somatic nervous system, we're dealing with skeletal muscle, primarily thinking of voluntary activity. When we see autonomic nervous system, we're thinking more along the lines of automatic responses that involves smooth muscle or cardiac muscle. Okay, smooth or cardiac. There we go. All right. Okay, so smooth or cardiac, typically with autonomic nervous system. So generally, then we see the control of your heart, the control of all of your smooth muscles in the body being regulated automatically. So that's kind of the difference. This involves your fight or flight aspects, what we call the sympathetic division. So, beneath this autonomic nervous system, we do see sympathetic and parasympathetic pathways or divisions. The sympathetic is going to be the pathway of response of perception and response to stress. So, when the body perceives stressors, uh, a response goes out along an autonomic sympathetic pathway that is different than the pathway of homeostasis. So the parasympathetic division, in essence, is your pathway of homeostasis. This is they call it the rest and digest pathway, the parasympathetic. So parasympathetic is kind of just where we're all at, hopefully, right now. Hopefully none of you are stressed out. Well, we're all stressed out, right? You guys are all stressed out all the time, probably. But hopefully when you come into this class, I know it is virtual. Hopefully some of that stress, you don't, you don't have to worry about it. Maybe except for the stress of all of this information. But even then, I don't want your hearts racing or your blood pressure going through the roof, or your respiratory going out of control, and your glucose going wacky. But when that's we reserve that for the bear. We reserve that for when we're driving down the road and we're on our way to work and the light's green, and out of the corner of our eye we see somebody blowing through the light, or maybe we're out on the country roads and a deer runs out in front of us, right? Our eyes, or you're driving down the country road and you see red and blue lights behind you, that can get the eyes bulging out, the heart racing, right? Are you walking in the woods, bear jumps out at you, or whatever. Like, it's Halloween, right? Spooky time. Some of us like to be a little bit scared or whatever. We're playing around with the sympathetic nervous system. It's there, kind of an as needed. It's on call. It's ready to get you kind of like, ready to either fight whatever's in front of you or run away from it. So if you live in the sympathetic world, and I don't mean with sympathy, right? We're not talking about the Hallmark card sympathy. This is a different type of sympathetic. Having that oh, I'm so sorry stuff. No, no, no. This is different. Okay. So this sympathetic has to do with stress. SS. Sympathetic is stress, your body's response to stress. And again, if we are living, or a lot of our patients, this is kind of the bread and butter, right, of what we do in the clinic, is working with individuals who are in have maybe zapped out the body because they've been in a chronic state of stress. So now they have high blood pressure all the time. They have different set points. They have maybe type 2 diabetes. They've got asthma. They've got COPD. They've got cholesterol issues. They've got all of these metabolic problems that relate to chronic stress. And so, stress is normal. It's as needed. But again, when we're living there, it really has a way of kind of uh, bringing you down over time. The body's got to rest. So the parasympathetic, that's the other thing that was sympathetic too. We have a lot of digestive issues going on in the world, certainly, from mouth to toilet. We've got digestive issues more than ever. But again, with sympathetic kicking in, we do see one system actually goes down. Most systems perk up. The digestive system actually goes through a vasoconstrictive process. We actually move blood from that area out to the arms and legs, right? If I need to run from the bear or fight the bear, or probably wouldn't win either way. So I don't know what, maybe freeze is the best, right? That's the more alliteration. We've had a lot of alliteration tonight, guys. We had all those F words and the muscles breaking things down. And now we're dealing with fight, flight, now freeze. Sometimes that's the response too. But either way, short of the freeze part, the fight or flight, we need skeletal muscles in full force, and so blood is pumping and really being directed toward your appendages, and that includes your head. So the head, the arms, and the legs are going to get all the blood, and so the abdominal area is almost like it's leached out of the blood. All of the blood vessels in the abdomen do this and kind of squirt blood down and over, up, down, and over. So yeah, so anyway, chronic stress is a real bear. So you want to be careful that the bear is not chasing you. We don't usually see bears around here. If the bear is your bills every month, or if the bear is your boss or your significant other or your kids, you can't perceive them that way. They're not the bear. They're not out to get you and eat you. And if they are, this class, I'm not a bear. I'm not out to get you. I'm certainly not out to eat you. And I don't think the subject matter is either. So it's normal to have some stress, but really understanding how to cope with stress and understanding your coping mechanisms, and really perceiving, right? What do you perceive? And then what degree is that going to cause an explosion to happen, right? Unexpected mail, with from a bill or what, that's some that could be cause for alarm, right? Or a loud noise or a loud boom in the middle of the night while you're sleeping. It's on and on and on, right? So there are many reasons why you need the sympathetic nervous system. Do you need it 24/7? You do, but it doesn't need to be activated, right? So anyway, parasympathetic is rest and digest. So once parasympathetic triggers kicks in, yeah, we used to hook up. We would have patients that would come in, and they would be on a million different medications, for usually for hypertension, usually for cholesterol, just the usual stuff, right? And they would come in, and some of them would have heart monitors because they were having issues with. I mean, they would they their adrenergic and sympathetic responses were just like almost just constantly there. So they would have resting heart rates, set points, resting heart rates of like 120, beats per minute. And they would come into the clinic, and we'd have them on the monitor, and and seriously, we would just have them lay on the exam table, and we would just kind of push on their shoulders a little bit, and maybe go grab their legs and just kind of stretch them a little bit, and grab their arms and kind of open them up, and then we'd have them breathing the whole time. We're watching their monitor, it's just plummeting. They would even feel themselves and say that they converted to the normal set point. They could literally feel the electrical change of their heart, get it from going like this to getting it just converting almost like instantly, just from the environment, from being in that setting. The problem is the second they leave, they're in the car, they're on the road, they're generally, those folks have poor coping skills, and and we talk about that too. Now look, Mr. Smith, when you leave the clinic today and when you get home, we want you to really be aware of your surroundings, but not hyper aware. We want you to, when you feel that heart rate go up, you can feel it going down when you're in here, so you should be able to feel it go up when you're out there. That's your trigger. When the armpit starts sweating, right? When the palms start sweating, you can feel that kicking in, right? And so when you feel that dimmer switch getting a little too bright, dude, you've got to recognize it and either breathe, or like, you've got to cope with that. Is it worth it? Is it really the bear coming to eat you, or is it just some dude wearing a Packers hat and you're a Bears fan? I mean, you just, or oh my gosh, that guy's got a Biden or a Trump sign in the yard. And I saw it today. My neighbor has Trump signs and flags in her yard, right? And this guy drives by today. I'm outside getting the garbage can, and this guy drives by today, and he slows down and shakes his fist at our neighbor's house just for having signs in the yard. I mean, what kind of mentality? That guy, I guarantee, is on a shitload of medication. He's probably as angry and type A and ready to explode at any minute. I saw him do it, complete stranger. I don't even know who he is, but just a sign is enough to get people just completely blown up. So it's pretty wild, right? You guys know what I'm talking about. You live it, right? You see it. Yeah, constant panic. Oh, Chicago traffic. Yeah. Oh, Lori, well, welcome, and I hope that we haven't added. Yeah, you're right. You're in that. Yeah. Sometimes it's not the patients either, right? It's your colleagues or your or the doctor, even. I mean, whoa, nobody wants a stressed out nurse or a stressed out doctor. I mean, you guys are stressed out enough as it is. I want to come into the clinic to kind of, whew, you know, just take care of business here, and it usually involves positivity. But oh, traffic, right? That's a big one. I mean, they've shown, I mean, the statistics have shown forever and a day that urban living, right? Urbanized living, primarily traffic, noise, the heartbeat of a city just takes over the physiology of an individual. And we see lifespans are lower. We see, just tons of problems in that urbanized society. But yeah. Yeah, good for you, Lori. Take a week off. Just yeah, I know. Please, yeah, good for you. Yep. Phew. So anyway, I promise I'm back to climb back down from that mountain. Sometimes sometimes I kind of live on that mountain. So, but anyway, yeah, it's so important. I mean, it's just I know we love it. We love helping people out, but geez, Louise, we like to see people help themselves, right? We want to be enablers, but we want to enable people to enable themselves to have better coping skills and to be more aware of their surroundings and what their triggers are, right? They talk about triggers and so you guys are kind of like psychologists, aren't you? Yeah, I think you probably have to take a psychology class. I'm not sure, but if you don't, and if it's like kind of like an elective or something, I would recommend it. They'd probably get into some pretty fascinating stuff. At the very least, you'll take like a medical law and ethics type course where you'll get into some of this stuff. So anyway, we're going to move forward. Glial cells. I'm not going to spend a lot of time on these next few slides. We've seen this term before. Remember, as we get into nervous system tissue, we really only have two cell types. They're either glial cells or they're neurons. And the glial cells are that negative space kind of around the neurons. They're the supportive tissue, I suppose, the supportive cells of nervous tissue. We do see five different types. We see more than five, but there are five major types of glia or glial cells. There are two that I kind of want to discuss. The other three are maybe a little bit more of an FYI. The first one, astrocytes, again, just the name of the cell tells you a little bit about it. Astro means star, so we're going to have a star-shaped cell. These are the largest and most numerous types of glia. These are going to be found throughout the nervous system, throughout the central nervous system. Primarily, we see them in large numbers, certainly within the brain. But these are going to transfer nutrients. They basically kind of have little arms that extend and connect to capillaries of our blood and of our bloodstream, and then they can bring the blood over the nutrients, I guess, over to the neurons. So they're sort of like a filter, filter process, kind of a built-in filter type of cell. Because again, neurons are very picky about what their set points are very, very small. So their ranges are very small for their set points. They require specific amounts and types of nutrients. And we have what's called a blood-brain barrier that does kind of inhibit a lot of things from entering into the circulatory system actually within the brain. So astrocytes are one of those lines of defense that kind of help out with that. No, that's a good question, Stephanie. We'll talk about this actually on Tuesday. When we get into the peripheral nervous system, there's a cranial nerve called the trigeminal nerve, and it does feed. You have two of them, right? You have a left side and a right side, and the trigeminal nerve has a lot to do with facial muscle control. So a lot of our muscular control, remember, it is voluntary, right? But it's also there's a lot of proprioception or kind of like involuntary subtle tone that's always within our muscles, right? Like our faces are not sagging or drooping. There is some sort of tone that's going on regarding, so that means there's some subtle muscle contraction going on. In fact, there's subtle neuromuscular connections that are occurring. And with trigeminal neuralgia, those connections may be inhibited, may be lost due to multiple reasons. There could have been a stroke that affected the path of flow down that trigeminal nerve. There could be there could be some musculoskeletal kind of compression of in essence the tunnel that the nerve passes through. So there's some sort of impingement on that trigeminal nerve. something has shut that nerve off, which could sometimes it happens from viral infections. So, but yeah, it's usually oftentimes it's one side of the face, and it could be again a symptom of something else, or it could be the result of uh, of something. So, so yeah, not necessarily glial related, but could be. Um, Yeah, neuralgia. Algia means pain, and neuro means nerve. So trigeminal is the name of the nerve. It has three kind of branches off of it. So trigeminal, and then that's the nerve. It's a cranial nerve, and then neuralgia means nerve condition of a nerve being in pain. In essence, so neuralgia. And kind of a misnomer because it doesn't necessarily mean that the person's in pain. It made the nerve is dysfunctional. It's probably better, maybe better called trigeminal dysfunctional dysfunction, trigeminal nerve dysfunction, or something like that. Trigeminal neuralgia just comes off the tongue better, I guess. But yeah, I mean, it can be painful, but um, it's usually a lack of sensation. That's the problem. Okay, so astrocytes. So you can see capillary networks are where we're going to have nutrient exchange, and we can see these astrocytes with their little kind of extenders plugging into the capillaries. Again, they sort of act like filters because out here you might have a neuron, and so we've got a little extra help with the blood-brain barrier. We also see a couple other guys up in the central nervous system, microglia and ependymal cells. Again, microglia are small glial, they're small glial cells, or small glue cells. Ugh. So anyway, microglia. Yeah. Ependymal cells resemble sheets. They're usually, we're going to see in the central nervous system, we have some ventricles and sinuses, or little cavities or rooms. So they're going to be lined with ependymal cells. So they might have some little, almost like little cilia on those as well, that are going to help with movement of some of that, what we call CSF, or cerebral spinal fluid. Oligodendrocytes and Schwann cells. I put those together because they're very similar to one another. Oligodendrocytes are found in the central nervous system. These produce the myelin that surrounds your spinal cord, for instance. We're going to see the spinal cord basically has a layer, a pretty thick layer of insulation called myelin, which is, we also know it as white matter. And this white matter, or myelin, is produced by specialized cells called oligodendrocytes. And they're also in the brain too. So central nervous system. Um, Oligodendrocytes, here they are. So you can see they're connected, and they're basically secreting myelin, which is kind of like a fat. Notice we see a lot of yellow. Yellow is indicative of lipid or adipose or fat. And fat is a wonderful insulator. So we have a myelin sheath. Okay, okay. You see the term myelin. But yeah, the oligodendrocytes are the ones kind of secreting that myelin. Now, some of you, all of you, I'm sure, have not. I would imagine all of you have heard of MS, which stands for multiple sclerosis. And osis means a condition of something, and sclero has to do with lesions. Okay, lesions, and lesions are kind of like scar tissue, or it's kind of like areas where there's been some sort of damage to tissue. And multiple, of course, means many. So it means a condition of multiple or many lesions. And the oligodendrocytes are the specific cells involved with MS. These guys, for whatever reason, they say it's an autoimmune disease. So something triggers these guys to basically go on strike in certain areas, and so they cease production of myelin. And so what we end up with is a decrease in insulation of the nerve, whether it's a spinal cord and or within the brain, the neurons of the brain. So they have sensitivities to heat and cold. They have temperature sensitivities. They have movement issues potentially as well, coordination issues. So anyhow, oligodendrocytes. We think of those being involved with MS. And then we do have some peripheral. So there's a neuroglia, right? It does look like neuralgia. Yep, I see where you're going, Stephanie, with that neuralgia and neuroglia. Yeah, very similar, just a couple of letters off. The glia is the glue. The algia means pain. Okay. Um, Let me go to this one. So the Schwann cells are basically the insulators for nerves of the peripheral nervous system. So we see Schwann cells are going to be secretors or producers of myelin that create what we call a neurolemma. A lemma is basically like a membrane. Okay, so the kind of the membrane around nerve fibers is going to have to do with Schwann cells and myelin. All right. Yeah, let me see. So if if I do get nerve damage in the like a peripheral nerve gets damaged, by whether it's some sort of blunt trauma or something, you know, the nerve likely repair. It's probably the Schwann cells and the myelin that's going to be damaged or bruised, if you will. Okay. Now, if an axon, so most, we haven't really done axons much, but we're about to. Remember, axons are the long tails of a neuron. And in the peripheral nervous system, the axons are typically pretty long. And so when when a neuron is damaged, if the cell body or the nucleus of the neuron is intact, then the nerve will repair. So when you hear that if I destroy a nerve, it won't repair, that's not true per se. If you destroy the cell body of a nerve of a neuron, then that's it. You're not going to get mitosis. There's no mitotic event going on with neurons. So neurons do not cell divide or go through mitosis. However, if you do damage to an axon or dendrites of a nerve, you even damage a cell body of a neuron, as long as the nucleus is intact and isn't destroyed, then yeah, the nerve is fine. Sometimes it takes a while to get that. Yep, sheath for a neuron. Yeah, lemma. Yeah, lemma just means lemma kind of means membrane or layer. So they're basically part and parcel, I would say. The neural lemma would be kind of the outermost aspect. So um phantom limbs. So there's think of nerves as a wire, okay? And the wire is live. The generator of power that's going through these wires is coming from the central nervous system. So as long as my central nervous system is working, I'm not impinging, whether it's through muscle or whatever, I'm going to have electrical flow. And we're talking about these motor nerves and these sensory nerve, both pathways have been embedded and ingrained within the spinal cord and brain for forever, right? I mean, I don't know how time is long, right? Long ago. So the nerves, the sensory nerves that we have, the pathways that from the tip of my finger all the way to my brain is going to be the same path. So now I cut my arm off up here, or we'll do the elbow, because it's typically, you may get it certainly the whole arm, but we'll just stick with the out. So if I have the same pathway of flow that's constantly going to the same spot up the same tract. It's there forever. If I cut this off, the nerve is still the pathway from that is still exist it still exists. So there's going to be a potential for that sensation that something is out there, something's beyond my stub. Okay, I don't know if that I hope that oh, I'm explaining that well. um so sounds like I gave the patient the right awesome, Lori. And now the so that's more of a sensation, right? Phantom pain, their phantom limb is more of a sensory type of thing. So, but yeah, the motor aspect, that pathway still exists as well. But we've terminated that, we've eliminated that muscle. So they oftentimes, if they've done an amputation, they'll actually try to get the motor pathways and the sensory nerves, so they're kind of like folded with whatever they have left of the skin. So you may get, so they can potentially decrease maybe the amount of phantom limb from there. So but yeah, that's exactly, so good.
Well,
Pat yourself on the back.
I had told the patient, I said, it's trying to unlearn something that the brain knows and has been knowing for 50 years. Now you've taken that out. It's trying to figure out what to do with it. I said, it could take a while, but it'll figure it out. Just for now, you're going to have to deal with it.
Yeah, it'll figure it out likely. Yeah. And or it may, I mean, it may not, like you say, even that individual, they're 50 years, but even like in their code, right? In our deeper human code, that is just ingrained. It's just there, of something as normal as having your right arm or your left arm or whatever. The body, the framework's there, and so we eliminate that wing of the house, and it still has that the electrical going through it. So yeah, it'll probably subside over time. We see it a lot more now too. We see more amputees, especially with the amount of type 2 diabetes. We're seeing more kind of below the knee foot amputations, below the knee amputations as well. um, Let's see. So glial, yes, indeed. So neurons, oops, neurons, just a couple of tidbits. We've already talked about them quite a bit. They don't have much. They just have a couple of major parts. Yeah, Bell's palsy, trigeminal neuralgia. They're definitely similar and linked, right? So I think it's the same nerve pathway, or the same nerve involved. It could be due to Bell's palsy, maybe more specific to an event that they can isolate that happened to cause the palsy. But yeah, similar space and area. Stroke patients, right? Sometimes, depending on the location of the stroke, will have that Bell's palsy, or what appears to be like a trigeminal neuralgia. Sometimes trigeminal neuralgia. So oftentimes, if it's from a stroke and Bell's palsy, it's the treatment, the prognosis maybe isn't as good over time. Whereas maybe like a trigeminal neuralgia may be more treatable. It could be because some folks get it in an acute fashion. It'll show up out of nowhere and then it'll go away out of nowhere. So Bell's palsy, maybe not necessarily quite as in and out. Let's see, cell body. So neurons, again, we're gonna have a cell body. The Of course, we're gonna have a nucleus in the cell body, but we also see a couple of other items we're very familiar with: ribosomes and rough ER. So that implies, just the fact that we have ribosomes implies that we're gonna have protein synthesis going on here. Golgi apparatus. Remember, Golgi does a lot of the packaging, so um, yeah, neurotransmitters. We're going to have little vesicles, oftentimes. Kind of vesicles, remember, take the S, with my mouse cursor, take the S out of vesicle and put an H in, and you have the word vehicle. So vesicles are kind of like little vehicles that transport chemicals, usually to the outside of the cell, or bringing things in from the outside. So anyway, neurotransmitters, those are another type of chemical that we see in the body. So anyway, and again, the proteins will help to maintain the integrity of the structure of the cell body, but we can also help with regeneration of some of the nerve fibers. Again, talking primarily of dealing with the axons or the dendrites. And dendrites, typically we see multiple dendrites, and they're going to be attached right along with the cell body. They're kind of like the hair, if you will, of the cell body. And these are going to be the sensory as this is what we call the input zone. So the input zone, in other words, when a sensory or a stimulus is coming into a neuron, it comes into the neuron via the dendrite. So we would say the dendrites are the input zone, and then the axon is going to be the output zone. Okay. Um, oh, and the axon and the when two neurons come together, or a neuron and a muscle, or a neuron and a gland, basically when a neuron and something else meet, we call that a synapse. Okay, a synapse. Okay. Oftentimes we find at a synapse, especially at the axonal aspect, that's where we're going to see neurotransmitters stored. And then those neurotransmitters, or those chemicals, will get released out of the axon of one neuron and then travel to the dendrites of a neighboring neuron. We're starting to get in. I need to reel it back in. We're starting to get into some physiology principles. So I don't want to scare anybody. I don't want to get too far ahead. So anyway, we can see the Schwann.
Wanna say night night?
Oh, night night. You be good. You have sweet dreams. Night night. Night night. Yep, he had a bath. He had dinner. He's got a passy. He's ready for bed. Man, I need that. That's good living, right? So we got to wait till we're elderly till we get that treatment. I can wait. Trust me. I don't want to. I'll wait a long. That can happen never, as far as I'm concerned. But yeah, neurolemma. That's the outer kind of covering of a nerve fiber or a neuron. Okay, the myelin sheath makes up the neurolemma, and the Schwann cells create the sheaths. Okay, so Schwann cells make the myelin sheaths, and then ultimately we get a neurolemma, which is basically the membrane or the outer coating. And we do have a little bit of a cytoskeleton. We have some microfibers, microtubules as well. When we look at the functional regions, again, I'm going to zoom through this because this is all advanced A&P. We do have the input zone. This is where, again, the stimulus is going to come in, and then we have what's called the summation zone, which also is referred to as the trigger zone. That's where we're summing, right? We're adding, basically, we're adding voltage to see if we get to a certain threshold to elicit the continuation of that stimulus. So when the stimulus comes in to a neuron, it's coming in at the dendrites in the cell body, and then we're getting kind of a voltage change. And if we get an increase in voltage enough to cause to reach a threshold, then we're going to continue to conduct the stimulus down the axon. So we call then the axon the conduction zone. And then finally, the output zone is at the terminus of the axon, or at the end of the axon. And then we keep perpetuating that impulse to the next neuron. So when we look at a neuron, we see these little dendrites in the cell body, or the soma. We've got a nucleus, rough ER. There's some mitochondria in there, a couple of lysosomes floating around, and some vesicles. But this is going to these dendrites are going to be connected to the axons of other neuron. So another neuron's going to plug in here. So an axon of a different neuron's going to plug in here. Stimulus comes in. So this is the input zone, and then it travels and we summit, keep adding and adding and adding voltage till we get to a certain threshold, and then we trigger the response or the stimulus to continue down the conduction zone, and then finally out of the axon terminus, what we call the synaptic knob, into the synaptic cleft. So again, this is sort of getting cart before the horse, but I don't know if it's necessarily get cart before. I'm just adding some teaser trailers of things to come, and maybe even giving you a reason to understand just these three anatomical spots of a neuron. So if you can remember dendrites, cell body, axon, those are the parts of a neuron. When I start adding things to it regarding how we get electricity to flow, how we get a stimulus to continue its pathway, uh, and I start talking about dendrites and cell bodies and axon, you're not going to be completely lost. Maybe partially, but not completely. We're not going to worry about this again very too terribly much. We do have different types of poles, if you will. We have what are called multipolar, bipolar, and unipolar neurons. I'll pull up the images. It's easier to see that way. The ones let me back up. This is a multipolar. You can see it has one pole. The axon is a pole. Then it has all of these other poles coming off of it. So that's going to be what we call a multipolar axon or neuron. And this multipolar neuron is more likely going to be seen, maybe we might see these in the brain. We might see these when we're talking about maybe some motor neurons, motor action, kind of spread out to different muscles. Okay. So multipolar, bipolar, we see one pole and then another pole. So you've got a pole coming in and a pole going out, and a little cell body. So what that means is all this energy is going to kind of come in here through all these different dendrites, and then it's going to condense itself and kind of funnel into what looks like a really long kind of what they call basically it's like this, almost like the summation zone but reversed. Okay, so usually we see that summation zone here. This time we can get some of that happening here before we get to the cell body and then the axon. And then unipolar, we see this a lot with sensory nerves, because we don't always want to get a cell body to kind of to slow things down, right? If I'm trying to send a signal that I just touched something really hot, that the temperature of this being really hot, that needs to go in a line, especially fast to the brain. So I don't want to see a lot of short axons and a lot of clumpy neurons together like this. It would take forever to keep perpetuating that stimulus that I just touched something hot. By the time my brain gets to it, there might be tissue damage at my finger. So what we have instead for sensory, we have a lot of unipolar, where you're gonna out here, maybe the tip of my finger, I touch something really hot, that signal is going to travel down one continuous axon, and that might have a cell body kind of off to the side that is kind of storing some of that info. It might be prepping to elicit some tissue repair down there, nutrient increase. We get the rough ER and the ribosomes and the Golgi activated. But yeah, we want to get that signal that it's hot out here. We want to get that to the brain fast. Whereas if I touch something here, it's hot, it's got to come through here. We got to wait for everything to sum, and then we finally get and pass through. So anyway, that's unipolar. Um, Again, we talked about afferent and efferent pathways. Sensory comes in, motor goes out. Afferent comes towards the central nervous system. Efferent goes away from the central nervous system. In the spinal cord, we do see a couple of or we do see an extra option called an interneuron. We'll see this shortly when we look at the spinal cord in particular. Interneurons are typically found in the spinal cord. For a few reasons. One, when I touch something, so it's something sharp, a thumbtack. So I touch a thumbtack, that sensory information is going to come to the spinal cord via this afferent sensory pathway. Now, in the spinal cord, so how does that information get up to my brain that I just touched something that was really sharp? Well, there are going to be elevators that go up to the brain from the spinal cord. They call them ascending, so going up, ascending elevators or ascending tracts. And these ascending tracts are going to take the information up to the brain that, yes, I'm touching something really sharp. And then the brain is going to say, okay, well, then you need to remove your hand. Okay, so then a signal goes down a descending elevator, this time a motor pathway, and then we send that motor pathway out to what we would call a motor nerve or an efferent neuron. It's going to go to a muscle, and then we're finally. That sounds like a hell of a lot of activity to go through just to touch a thumbtack and remove it. So we don't always need to involve the brain to make that decision. So what we do is have this specialized interneuron that is going to connect the sensory pathway with the responding motor pathway. So under certain conditions, if the strength of stimulus out here is really loud because I touched something really sharp, that stimulus is going to zoom really fast. It's going to hit that interneuron in the gray matter of the spinal cord, and it's going to perpetuate the continuation of that stimulus, this time through an effector to get me to pull my hand away, almost without the brain having to make that decision to do that, right? The brain doesn't need to be involved necessarily to get my arm to pull away from a hot surface or a sharp surface. Now, of course, the brain is, we are sending, this isn't, it either does this, it either does that, or it does this. No, no, it's not an either or, it's a both, right? So the strength of the stimulus will determine how fast we get a response, as well as how we're going to transmit that information up to the brain. So I can send that signal through an ascending track that, yep, we just touched something hot or something sharp. But don't worry, we've already moved. The brain already knows that based on what we call proprioception, which is your motor kind of sensory motor connection of where you are in space. So the brain's already knows that you've removed your hand, but what it's doing is storing long-term information for future reference. So now if my visuals see that sharp object or see that hot plate or whatever, it's, there's going to be maybe kind of a preemptive, like instead a proactive kind of avoidance versus a reactive response. So anyway, interneurons. Okay, so three neuron reflex arc. So the afferent pathway is the sensory, we get the interneuron, and then the efferent pathway going out. Okay, so afferent impulses to the CNS from the receptor, efferent from the CNS to the muscle. And it could be a gland too. It doesn't have to be a muscle per se. This is getting into too much stuff, so let me move on from that. Maybe that's getting into too much physiology. So I want to keep going. A two neuron arc then doesn't involve that interneuron. So three neuron reflex arc. The third player is going to be the inter. Inter means between. Third player will be the interneuron. We eliminate the interneuron. We only have two. We've got the afferent sensory and the efferent motor. We have and where they connect, we have what's called a synapse, right? Where a neuron connects to another neuron, or a neuron connects to a muscle, we have what's called a synapse. All right. Real quickly, let's take a peek at nerve layers. This is no different than what we just saw with muscle, right? We had the epimysium with muscle, and then the paramysium, and then the endomysium. With nerves, it's the same story. We've got a bunch of tubes of fibers put together and filaments bundled with epineurium, and then perineurium, and then endoneurium around the entire nerve itself. So epineurium on the outside, and then we have these bundles of nerve. And by the way, muscle fiber is a muscle cell. Nerve fiber would be a nerve cell. So that's what we see here. We see Schwann cells all the way inside and the axon. So the neuron, remember, is the cell. Okay. So this is the cellular level. And then the bundle of those neurons is called a nerve fiber. Okay. So epi on top, peri around the bundle, and then endo all the way around each one of these. So the endoneurium almost acts as the neurolemma. Okay. So the endoneurium is a lot like the neurolemma, okay, that the Schwann cells produced. So this is one neuron down here. Okay. One of these little blue jobbers. That's one axon of one neuron. So look at all these axons of these neurons and how they're bundled. And then we bundle them some more. And then we finally get what's called a nerve. So the nerve is surrounded by epineurium. Okay. And nerves have different diameters, just like muscles do. And again, we have what are called tracts. I mentioned that a little bit ago. These are the elevators that go up or down that are contained within the spinal cord. We'll look at them in more detail in a little bit. White matter is myelinated. So we've seen that before as well. Myelinated is white matter. The gray matter in the central nervous system are going to be bundles of nuclei. We're going to see a whole bunch of nuclei kind of compacted, and then all of these axons of these nuclei of these neurons are going to be making up a lot, are going to be covered in the myelin. So the myelin covers up a lot of the axonal aspects. So wherever we see a lot of white is where we're going to see that a lot of axons and a lot of myelin covering these axons. Where we see gray is going to be where the neurons are going to be, the nuclei of the neurons, the cell bodies are going to be more condensed. And then the PNS, the gray matter, we refer to that as ganglia. So we'll see that again coming up later on. Mixed nerves, we have sensory and motor that do have both. So some of these nerves. So we look at this nerve. Some of these they're typically mixed nerves, right? We're going to see motor pathways in here, and then so this bundle could be a bunch of motor nerves that are bringing information back out to the muscle. This bundle over here could be a bunch of sensory uh, uh, neurons. So if it's mixed motor, then it just means we have a more motor than sensory, but it still would have sensory. We see we have some that are mixed sensory, meaning we have a lot more sensory with a few motor. So that's all that's talking about. And I guess so. In other words, like a nerve isn't just sensory or just motor. It's typically going to be mixed. Holy cow. Let me zip through a couple of things here. My plan really was to start central nervous system next week anyway. So, but I do want to discuss just a couple of items real briefly. Primarily the meninges or the coverings. We do see the coverings of the brain. And so we're going to focus on brain and spinal cord for just a few more minutes, and then I'll let you guys go do whatever you need to do. And then Tuesday, we're going to really pretty much conclude the central nervous system, and then probably get into the peripheral nervous system a little bit as well. But the central nervous system does have some protection. Certainly, we know that the skull and the cranial bones, as well as the vertebral bones, are going to provide some very good protection. Now, underneath or deep to those to the bony coverings, we do have three meninges. Meninges are going to be special layers of tissue that, in essence, kind of help to support the brain and spinal cord. But we also will see the spaces between these meninges where fluid passes through. So I just wanted to introduce you to the meninges briefly. We do have three different meninges. We'll start at the deepest one. So when we look at the brain, we're looking at a frontal or coronal section. We can see white matter surrounded by gray matter. So that's the reverse of what we see with the spinal cord. Remember, spinal cord is gray on the inside, white on the outside. With the brain, we have white on the inside, gray on the outside. And the gray, again, the gray is going to be where the nuclei generally are going to be. And then out here is where we're going to find, or in here is where we see a lot of axon, dendritic activity. A lot of the myelin is contained within here. So anyhow, we do have this outer layer called the pia mater that is going to be snug right up against the brain tissue. So that's your first meninge. Your deepest meninge is pia mater. Mater means mother. All three meninges are going to be mater or mother. The first and deepest one is the soft mother, and that's good. We want a soft mother if it's touching, our brain. So you don't want a tough mother touch your, tough mothers are good, but uh, they're a little more on the superficial area. So we'll see that later. So pia mater, the soft mother, is going to be covering the brain right up against it. And then we can see a little bit of a space right here, just superficial to the soft mother or the pia mater. That's going to be filled with little kind of kind of a fibrous web. We call that space the sub arachnoid space. And arachnoid means spider. So we do see kind of a web-like appearance, subarachnoid space. So the fact that it says sub at the beginning means we're below whatever we're describing. So below the arachnoid is what subarachnoid means. So the second layer of meninge, or the second meningeal layer, is called the arachnoid mater or the spider mother. Okay, so you've got the middle layer of meninge is called arachnoid mater. And then we go just superficial to the arachnoid mater. We'll come over here. We see another space. This one's called the subdural space. Okay, subdural space. So below the dura. So that means the next layer, the most superficial or the outermost layer, is called the dura mater. Dura, that means tough. That is your tough mother right there. Probably a couple of those in here. I don't know. I don't think you moms. I hope you're more pia mater than dura mater. Although there's a fine balance, right? You got to be a little bit of both sometimes. It's a balance of good cop, bad cop, right? In my house, I'm good cop. But don't tell anybody. Ooh, I hope they don't watch these. Uh, I doubt it. They hear me enough. They don't need to watch these to hear me. Uh, hmm. But anyway, yeah. Oh, when daddy is bad cop, which I rarely, it's actually daddy's principal, like some because we homeschool. So yeah, sometimes the principal has to come in and be principally. So anyway, oh yeah, oh Lori, whoops, yeah, it happens. Hopefully, that's all it was, and not reckless. And he had seat belt on, and there was no alcohol, and there was, hopefully, it's a learning opportunity, right? Learning opportunity. I think I got my first speeding ticket about maybe a month or two after I turned 16, so I got it out of the way quick. Oh, dad was, oh yeah, dad. Oh yeah, yeah. It's certain, right? We there, there's like we have our different like areas that we cover, right? Driving, that's usually, yep, dad. Tough mother. Yep. Tough Potter, Dura Potter, Potter and Motter. All right. Let's see. So anyway, yep. Dura Mater is the outermost layer. It's the toughest layer. And actually there's a little space in especially we see it down in the lumbar region called the epidural space. You guys have all probably heard of that, but that's going to be the space kind of even more superficial or above. So you'd have the bone, and then you have the dura mater, and then there's a space in between. That's going to be the epidural space. That's why the anesthesiologists make such big bucks, but they also have such high liability insurance, right? Because that's a very, very fine spot that I need to get that catheter to go in into that epidural space. If I go just a little too far beyond that epidural space, I'm now maybe in the subdural space. And if I go too far, I'm now in the subarachnoid space. And that's where we see what's called cerebrospinal fluid. So there's a special fluid that's flowing around the brain and spinal cord within what we call the subarachnoid space. We also see that fluid contained within the brain and spinal cord in what we call ventricles and sinuses. So you have little rooms inside of your brain where we see this cerebral spinal fluid, or CSF, kind of born and circulating. And then again, we see it kind of coating the outer surfaces as well. That subarachnoid space is where we find CSF. So if I need to do a lumbar puncture or a spinal tap, I'm going to have to go past the epidural space, and I'm going to go all the way down into the subarachnoid space to withdraw some fluid. So the point of an epidural is for pain management. So we just basically need to get some anesthesia, kind of surrounding the nerve, surrounding the spinal cord, and then the nerve. We don't want to go into the subarachnoid space. I cannot have that anesthesia going and mixing in with your CSF and going up in the brain. That could cause severe headaches and a whole. Women delivering babies have enough going on. They don't need an epidural gone bad. Okay. That'll just about do it. Those are the meninges, the space. There's that CSF I mentioned, cerebral spinal fluid. And these are the ventricles. You have little rooms or ventricles or sinuses within the brain and within the spinal cord. Okay. That's it. We'll stop there. We'll start off on Tuesday with spinal cord. We'll get into spinal cord and then brain. I'll talk a little bit more about ascending and descending tracts. I'll also talk a little bit more about motor and sensory pathways. We'll look at sensory pathways coming into the back of the spinal cord, and then those elevators going up the posterior, the back or the dorsal portion, and then we'll see some of the motor elevators coming down or descending and heading out the front door to deliver that motor response. Then we'll talk a little bit about some of the regions of the brain, specific brain regions. Then we'll jump right into cranial nerves and spinal nerves a little bit. And then next Thursday, in the evening, we're going to have Lori, a different Lori, not you, Lori. We're going to have Lori she's an A&P instructor. She's one of my colleagues. She also teaches general A&P, but more likely you would have, her last name's Janus, Janus, Lori Janus. She teaches at the Burlington campus primarily. In fact, that's kind of her home base is Burlington, but she teaches microbiology. And those of you who have to take microbiology, and you're going to be taking it at either Burlington, Elkhorn. I don't think we do micro there anymore, but we do at Burlington. Lori is going to be the one who teaches that. If you take it at Kenosha, you would have a different instructor, Richard. So, but anyway, Lori Janice is going to be with us on Thursday night next week. She basically just wants to observe and see how we do things. And my goal, like I said, I'd like to do a little bit of visible body stuff, and I may try a couple different things. I mean, we'll see what happens, but so just be who you guys always are. You're an excellent group. You're very vocal in the chat, as well as in the video section, which, and those of you who aren't comfortable or don't want to do video or even talk through the audio, I'm perfectly fine with that. And just because Lori's in here next week, kind of observing, you don't have to change who you are. If you don't have to, all of a sudden start, you know doing something that you normally wouldn't. So we're just going to conduct our business as we normally would. But like I said, she also teaches general. She's just started using visible body, so I think she kind of wants to see, if how we use it, and that. And so anyway, I just wanted to give you a heads up that that's going to be going on. We're just going to keep trekking along and doing what we normally do, uh, regardless of who's kind of hanging out with us. So that's it for tonight. Do you guys have any questions? Like I say, you want to keep plugging away at your stuff, and I might not be here on Tuesday. I have to take my in-person part of CPR recertification. Okay, that's cool. Lori, are you busy Tuesday from 11:40 till about 1:40? Because I do the exact same thing at that time. So if you're available, you could always dip in Tuesday at that time. Okay, cool. Yeah, everything's the same link, same everything. You just hop in. I usually open it up about 11:30, and so yeah, you hop in, and then we already did a little bit with the peripheral, or with the peripheral. We already did a little bit with spinal cord, but I will go back through it because just this morning I had a pretty small crowd, so I'll go back through, so you won't be necessarily missing out on anything. But usually we're at the same pace, as the both classes are at the same pace. So cool. That holds true for all of you. If you can't make it on a Tuesday or Thursday evening, and you really like being in the live Zoom, you're certainly welcome to come at 11:40 on Tuesdays or Thursdays as well. So anyhow, you guys have a great weekend, and I don't have too much of anything else. And again, those of you who came in